like to say good afternoon. Welcome to the sixth installment of the Alliance's COVID-19 webinar series called Ensuring Racial Equity During the COVID-19 Homelessness Response. Now, I want you all to keep in mind that there are more webinars that will specifically focus on racial equity to come, and that the Alliance's Racial Equity Network will also be releasing more resources. So I want everybody to look out for that. Also, I have to say, I'd be remiss if I didn't mention this, that all of our webinars should have discussions on racial equity. And so we've planned that for all of our webinars, aside from the ones that specifically focus on racial equity. So we just want to make sure that we're recognizing that we are highlighting this issue, but it is an important issue that we should be talking about throughout. So anyway, hello everybody, I'm Crawford. I'm a policy analyst at the National Alliance, and I am pleased to announce our dynamic panel today to cover this important topic. So we're going to have a wonderful moderator, and that is Pascale Leone, and she is the Director of Diversity, Equity, and Inclusion at CSH. And then next, we will have Dr. Lecia Kellum. She's the President and CEO at St. Joseph Center. And last, but certainly not least, is Melissa Haley, Program Director of Supportive Services at Volunteers of America in New Orleans. We definitely want to hear about what's going on in New Orleans and Los Angeles. That's where Dr. Kellum is from. Okay, so let me give you a couple of make a few basic housekeeping announcements so we can get this webinar started. So the webinar, it is being recorded. So if you miss something, don't worry about it. If anybody who's registered, you'll have access to the links, and then also we're going to present some additional information. So no worries there. Everyone is muted, and we have enabled the chat function, but you can enter questions if you look at the Zoom Q&A, and we'll get to the questions at the end. Now, again, if your question doesn't make it, have no worries, because if you miss it, I want you to sign up for our Ending Homelessness form, or I think it's called Ending Homeless form. And it's on our site, and we will continue the discussion there. So we're going to have a lot of opportunities to keep talking about racial equity and COVID-19. And so just a couple of more announcements. Our next webinar is next Tuesday, April 21st at 3, and that's on data collection resources. And then, of course, we all want to know what's happening with federal funding, and so that will be on the following Thursday after the 21st. And so without further ado, let's kick off what we came here to do. Let's talk about centering racial equity in our homelessness response to COVID-19. Mrs. Leone?
Thank you so much, Sean. And it's great to be in virtual community with you all today. I want to send out thoughts of healing and comfort as we're all navigating through these really strange and unsettling times. You could go to the next slide, please. As Sean mentioned, I'm Pascale Leone, and I serve as the Director of Diversity, Equity, and Inclusion at CSH, the Corporation for Supportive Housing. But I'll share that my most demanding job of late is serving as the personal assistant and short order cook for my 3- and 1-year-olds. For those of you who are unfamiliar with CSH, we're a national nonprofit working to eliminate barriers to housing stability for highly impacted populations. Next slide, please. And so, as Sean had mentioned, I'm really excited to moderate today's timely and critical conversation with our dynamic and inspiring panelists. About a month ago, I wrote a blog examining the intersections of increased vulnerability and further marginalization amidst the corona crisis if the work of racial equity is not sufficiently centered. And so what we're witnessing and what today's conversation will illustrate are the glaring racial and ethnic disparities in confirmed cases and the deaths across the country, and especially in predominantly Black and Brown and low-income communities like New York City, New Orleans, Detroit, Milwaukee, and Chicago, and others. And so these disparities, I'm sure for many of you, come at no surprise, given the higher rates of pre-existing health conditions experienced by people of color that make us particularly vulnerable. However, what's been absent from a lot of these narratives are the long-standing social, environmental, political, and economic inequities that have greatly contributed to poor health outcomes. And so I came across this quote from Dr. Tamara Jones, a family physician, epidemiologist, and visiting fellow at Harvard, that summed it up quite well. She said, COVID is just unmasking the deep disinvestment in our communities, the historical injustices, and the impact of residential segregation. This is the time to name racism as the cause of all those things. The overrepresentation of people in color and poverty and white people in wealth is not just happenstance. It's because we're not valued. Next slide, please. And so the scale of the impact of the pandemic is certainly still unfolding, but one thing is for certain, COVID-19 is not impacting all communities equally. And so as states and localities have been reporting, African Americans and other marginalized groups are disproportionately impacted given a confluence of existing factors that COVID has only served to amplify. Individuals experiencing homelessness and housing insecurity are at acute risk as their abilities to safely shelter in place are just simply unrealistic. And according to the National Low-Income Housing Coalition, people experiencing homelessness who contract the virus are 2 times as likely to be hospitalized, 2 to 4 times as likely to require critical care, and 2 to 3 times as likely to die than their housed counterparts in the general public. And for African Americans, who represent about 13% of the general population, but account for about 40% of people experiencing homelessness, we're also overrepresented among those who hold hourly low-wage jobs, including those deemed as essential workers, putting ourselves and our families and communities at further risk, not only to contract and spread the virus, but African Americans are also represented and overrepresented in the service and other industries that are deemed as non-essential, leading to record unemployment numbers. I think the numbers that came out today were about 22 million who have filed for unemployment nationwide. And I think, as we've been saying for decades, race and place matters. A recent Harvard study concluded that people living in counties with long-term exposure to particle pollution are at greater risk of dying from the coronavirus. Next slide, please. And so this interplay of the social, economic, political, and environmental factors show that this issue here is indeed structural. Since the moment that stolen people stepped foot onto the stolen land, we have had racialized health disparities. The legacy of structural racism has resulted in disproportionate health outcomes for African Americans for centuries, and the medical profession has been deeply entangled in it. We can go far as back as the role of physicians during the transatlantic slave trade, to their certificates of soundness for the selling of humans on auction blocks, to even the horrific roots of American gynecology. And as civil rights lawyer Brian Stevenson notes, slavery didn't end in 1865, it just evolved. And I think the same can be said about this nation's segregated healthcare system. We're all familiar with the Tuskegee trials as the longest medical experiment in history to knowingly withhold treatment from human subjects, to modern day proliferation of mass incarceration, where today's jails and prisons are also serving as our largest providers of psychiatric care, to the HIV/AIDS epidemic that is still a crisis in certain communities some 40 years after reaching this nation. And we could talk about the disparate maternal mortality rates and just a large body of research that reveals that the deadly role of implicit and explicit bias in our healthcare system. And so I highlight all of these to contextualize the factors that have led to our present day broken systems of care. For far too long, there has been a lot of talk about racialized inequities, but now really is the time for action. Okay, to the next slide, please. So how do we design equitable responses to the COVID-19 crisis? We do so by designing solutions that center the voices and the experiences of those most impacted, those continuously on the margins. We do this by collecting uniform and inclusive data to better understand who's received tests, who's tested positive, who's been hospitalized, died, and recovered. And we also need to know their housing status. Without this information, we can't fully understand the scale and the scope of this pandemic, nor can we responsibly nor adequately and equitably distribute the critical and limited resources that are coming from the stimulus packages. We need to build more meaningful and inclusive decision-making tables, You know, state and localities are setting up task force and teams to examine the racial disparities, as well as to determine how the stimulus funds are flowing into which communities. I encourage you all to fight to be part of those tables, but once you're at those tables, to look around. Are the groups who are most impacted represented? And remember, if you're not at the table, right, you're on the menu. And we need housing-focused interventions that center equity. A great tragedy would be if we move individuals temporarily sheltered in motels and hotels back to shelters and back to street homelessness. We had a crisis before this crisis. And so if we could use taxpayer dollars to very quickly buy up unused motels and hotels, we could surely and smartly invest in long-term solutions like permanent supportive housing. And lastly, I encourage you to play the long game. You know, as money starts flowing to their communities, both in homelessness and housing systems, it's important that we plan for the long term. And that also means an opportunity to disrupt and to redesign inefficient and inequitable systems that no longer serve us. Next slide, please. And I know that Lecia and Melissa will do a deeper dive on this, but for providers who are looking to focus on equity, I certainly encourage you to apply an equity analysis to your current emergency protocols. What is the composition of staff on the front lines and those who are able to work remotely? Is it equitable? And for those on the front lines, how are you able to meet their needs, whether it be childcare or access to protective equipment? And remember that empathy is a practice. Continue to virtually connect and remind your peers that you're all in this together, and assure your employees that their health and economic security are also your priority. And remember that words matter. Be conscious of the language that you use to communicate with staff, residents, and the broader community. Be vigilant to combat against language that stoke ungrounded fears and promote othering and further marginalization. And lastly, to be trauma-informed. Trauma-informed care is essential in times of crisis. For clients and staff alike, many are dealing with lots of grief and loss and maybe reliving symptoms of past trauma from recent and similar events. So it's important that information is relayed in a trauma-informed way. The next slide, please. And so on this next slide, there are a lot of experts supporting communities in tangible ways to lift up the equity work. And so you're not alone in this. You know, this virus has already made this indelible impact on our global community, but so do the decisions we make in response to it. Now is always the time to prioritize the issue of equity. Our collective fates and are inextricably linked, and they're also depending on it. And so I thank you guys so much for this opening. I'm so excited to then turn it over to Dr. Lecia Adams-Kellum, who's going to talk about her experience in Los Angeles. Lecia, are you on?
I am. Thank you so much. Good afternoon, everyone. As you heard, my name is Dr. Lecia Adams-Kellum, and I'm the president and CEO of St. Joseph Center. Next slide. In my presentation today, I'll be reflecting on a number of aspects of what Pascale noted in her introduction. Next slide. Next slide. St. Joseph Center has been serving low-income and homeless individuals on the west side of Los Angeles for over 40 years. We serve vulnerable communities in a number of areas, and they include outreach and engagement, housing, mental health, and education and vocational services. Annually, we're reaching about 10,000 plus people. Next slide. Thank you. Next slide. In recent years, there's been an increased acknowledgement of the racial disparities in homelessness. And this is due in large part to the tremendous work of Chandra Crawford at NIH and the Racial Equity Network that she referenced earlier. The data reflected in this chart illustrates what we sadly are becoming more aware of, that while Black people make up 12% of the general population in this country, they make up 40% of those who are homeless. And we see this disparity is not explained by deep poverty rates. And certainly we see Native Americans are also overrepresented among the homeless. Next slide. The number of people who are homeless in Los Angeles County is also reflective of a deep crisis And it's a crisis that's been underway before the pandemic. As you can see, there are about 36,300 homeless in the city of LA and almost 60,000 homeless in the county of Los Angeles. Next slide. And as I mentioned, as you saw on the national level, Black people are also overrepresented among the homeless in LA County, where Black people make up only 9% of the general population. We make up 33% of those who are homeless. Next slide. It was this disparity that led to the creation of the Los Angeles Homeless Services Authority Ad Hoc Committee on Black people experiencing homelessness. The purpose of the committee was to examine the factors contributing to the overrepresentation of Black people among the population experiencing homelessness. We set out to identify the opportunities available to increase racial equity within the homeless delivery system. And we developed recommendations to more effectively meet the needs of Black people experiencing or at risk of homelessness. Next slide. The committee spoke boldly, and I'm telling you, it was not easy. We called out structural and institutional racism as cause for the disparities. And it's true that our country's dark history is to blame for the racial injustice and institutional racism that is the outgrowth of the brutality of slavery. As Pascale noted, the Jim Crow era and the white supremacist ideology, the redlining and the economic disparities that came out of those discriminatory practices, and the long-lasting and destructive effects of mass incarceration. Next slide. And so, COVID-19 and racial disparities. We know when it gets hard for everyone else, it gets twice as hard for Black people. And with COVID-19, we see the same is true. In LA County, we're seeing a similar trend as seen across the country of a disproportionate number of Black people contracting the virus and dying. In terms of the rate of COVID-19 cases seen among Blacks, as this chart notes, there's 74 cases per 100,000 people for Blacks, and with a death rate of 6 per 100,000 people, compared to white people with a case rate of 65 per 100,000 and a death rate of 4 per 100,000 people. And yesterday I received additional data from the LA County Department of Public Health, and this is what they indicated. The total death from COVID-19 in Los Angeles County is 402 to date, and our mortality rate for COVID-19 is 3.8%. For the 330 deaths where race and ethnicity were identified, 15% are African American, though we make up, as I said, 9% of the population. 17% are Asian, making up 15% of the population. 34% are Latinx, which are 39% of the general population, and 31% are white, making up 36% of the general population. And clearly, a disparity is seen of who is dying from the virus. Next slide. This past weekend, Eugene Scott identified 4 reasons coronavirus is hitting Black communities hard in his Washington Post article. He notes, number 1, higher rates of underlying health conditions such as hypertension, heart disease, diabetes, lung disease, in which challenges caused by these illnesses are exacerbated by the virus. And number 2, as you heard earlier, Blacks are overrepresented in the service industry, particularly in these essential jobs. We also see that there's a great deal of misinformation, including the idea that African Americans somehow could not be infected and that young people weren't at risk of getting sick. Some Black people simply were not getting accurate information, and we know that, or information that they could trust. Number 4, housing disparities. We've seen a high incidence of asthma in young Black kids due to living in older buildings. We know that. We see that people of color are living in more densely populated areas, in urban areas, we know, and of course, multi-generational housing spaces that put us all at greater risk. On the bottom floor of my house, I've got a senior citizen space, my 80-year-old mom in the middle area. I've got kids running around. I've got a kid home from college, a kid doing dance in another area of the house, and 2 offices. And when those different generations come together, there's a chance for risk, and there's a chance for infection. These factors were also echoed by Patrice Harris, the president of the American Medical Association, in terms of why so many Black communities are being hit hard. Next slide. I believe that the recommendations that came out of the ad hoc committee report are particularly relevant at this time, as we're seeing so many Black people impacted by COVID-19. But in the interest of time, I want to highlight 3 key insights. First, it's important to ensure that service providers understand the impact of institutional racism and racial bias on our work and on Black people experiencing homelessness. It's critical that we understand the impact of racial trauma and how services need to be delivered. Next, the report noted that we must begin to include Black people, particularly those with lived experience, in policy design, implementation, evaluation, and service delivery. The report also highlighted the importance of using a racial equity lens in our sector. Next slide. I believe that the use of a racial equity lens is critical at this time, and more than ever due to the pandemic, because a racial equity lens helps us understand who we expect will be most vulnerable and which communities we should be targeting during this time. So the use of a racial equity lens would have allowed us to quickly target and do outreach to Black and Brown communities in light of the structural and social determinants of health, particularly because we know that in those communities, there's higher rates of underlying health conditions. We know that Black people are extremely vulnerable, and being homeless just exacerbates the situation, because unsheltered people can't do the things that we're all doing here at home or even in our offices: washing our hands, social distancing, and self-quarantining. A racial equity lens also informs us of what services should be offered. I believe that testing of Black people is critically important, particularly those who are homeless, 65 and older, with multiple health conditions, since we know that Blacks are contracting the virus and are dying at alarming rates. You see, a racial equity lens might also suggest that when we're thinking of sheltering folks who are still out there on the streets, that we're prioritizing environments such as motels and hotels rather than congregate spaces due to the chance of infection. A racial equity lens also informs us of when services are offered. Due to the gravity of this situation, we must move with urgency because we know certain communities are more vulnerable than others. And I'm happy to say that in Los Angeles, this is a picture of one of the hotels that we opened due to the innovations and work with FEMA and the state, that we could then target those most vulnerable. And we know that a number of those residents are African American. Time is not on our side, and we know that. And lastly, I want to say that a racial equity lens informs us of how the work is done. Effective approaches to reaching Black people and Brown communities during this pandemic is critically important. It must be centered in a space of cultural sensitivity and trauma-informed care. We must focus on education, compassionate and culturally sensitive messaging. And we must understand there's a lot of mistrust of the government. So we have to watch the way and language in which we are communicating information. Next slide. As you heard earlier, the use of a racial equity lens during a crisis like this also means that we must reflect on who is on the front line. We can't ignore who's being put at risk. And if there's a disparity, we have to be ready to address it. And there is. According to the 2017-2018 data from the Bureau of Labor Statistics, fewer than 20% of Black workers are able to work from home compared to about 1/3 of their white counterparts. Many on the front line are service workers and essential staff, delivery drivers, police officers, subway personnel, outreach workers, emergency shelter staff. Many of them are Black and brown people. And sadly, but we have to admit this, that the folks on the front line are often the people with the least amount of power in our organizations, and they're in the lowest salary bracket. Next slide. I want to end with a few recommendations. First, make a commitment to using a racial equity lens within your organization or COC. Be willing to ask tough questions about race. Since we see that there is a disparity in who we are putting on the front line, we need to own it, and we need to do something about it. One thing we can do is compensate frontline staff with hazard pay and bonuses. In Los Angeles, LASA and public officials are allowing us the flexibility actually to take underspent dollars in our contracts to provide a hazard pay. And I must tell you, it made me feel so much better to know that as I was putting people out there and knowing that they were at greater risk, that at least I could pay them for what they were doing. It's critically important to our work and to addressing that disparity that emerged. After the pandemic eases up, another recommendation is give the frontline warriors that put their lives at risk the much deserved raises and adjustments to their salaries that they deserve. And promote those go-to people, and there's a lot of them. I talk to them at midnight and 6 a.m, those who are watching over our programs and making sure our brands continue to be reflective of our missions and our commitment. Those frontline workers have put themselves on the line, and they deserve to be recognized. And this pandemic has shown us the true value of those frontline folks. Let's make a concerted effort to value them and all levels of our agency. And lastly, let's demand system change. Whatever we've done that worked in this pandemic, whatever we've done to swiftly house Black and brown people, let's keep doing it. I don't want to see people coming out of our shelters and out of our hotels and motels that we've secured and moving them back on the street. I don't want to see flooding the streets again with these amazing people, these vulnerable folks who deserve a place to live. Thank you.
Hi, I'm Melissa Smith-Haley. I am a program director at Supportive Services at Volunteers of America, Southeast Louisiana. We have been quarantined in our community for better than a month now. Experienced a high amount of deaths. My husband, 3 of his classmates have died because of COVID-19. We know people. This is not a CNN story. It's not an MSN story or a Fox story. These are people in our community. These are our neighbors. These are our coworkers. These are our friends. The impact of COVID is personal in our community. And we know and we rebuke all stereotypes that pertains to how and why people are being impacted by the disease. Slide, please.
I'm sorry to interrupt, Melissa. This is Pascale. I think you're going a little bit in and out. It's just a little hard to hear you if you get a little closer to the speaker.
Okay. Is that better?
One more time?
Is that better?
Yep, that's good. Thank you.
Great. So basically, in the city of New Orleans, it's important to us to know who is and who's servicing us. And the people that are doing the work. While some of us have the opportunity to home and
Melissa, this is Sean. You're still going in and out. So when we did the practice call, did you put it on conference to make it louder, because we really can't hear you?
no, I haven't touched anything.
Okay, see now, just how you were talking now, just when you said, no, I haven't touched it. So maybe you need to get closer, because you have an excellent presentation and I want to make sure we can hear you. And I kind of hate to ask you to start over, but we have time, but you were really going in and out. And I actually just text you because I didn't want to interrupt, but we just couldn't hear it. I don't know why it was going in and out, but when you just spoke into the mic just now, we could hear you clearly.
Can you hear me now? Can you hear me clearly?
Just like that. Yep.
Yep.
Awesome. I'm so close to my screen, y'all. I can see it, and I feel like we're intimate at this particular point. I hope you can. I hope you can hear me well. And as I said when I started, that COVID is personal in our community. People who are dying are our post workers, are our coaches, neighbors, and our friends. My husband, 3 of his classmates, all around 50 years old, have died. They were well a week or 2 ago, and they all have transitioned because of COVID-19. So it is important when we hear the stereotypes about who is getting COVID and why they're getting COVID, and primarily because they are not following best practices. We are totally aware that there are other factors, many of which have been discussed and are historical as to why we see such a large racial disparity. So it's important to know that while some of us get an opportunity to sit at home and listen to webinars and work, that is a major convenience that many people who don't have. Of the frontline workers in the community, 1/3 of frontline workers have a minor child at home. This is really important because you have to, while you're working at grocery stores, while you're driving buses in a community, you have to identify who can take care of your child and to have those children in a safe environment that is COVID-free. That is very difficult to do, but it's also equally difficult not to go to work and provide for your family. More than 1/3 of workers in many frontline industries live in low-income families. Roughly 1/3 or more of low-income workers are found in 6 of the top 5 occupations in grocery stores, social services, convenience stores, childcare, and drugstore industries. Overall, almost 1/4 of frontline workers, that's 23%, live in low-income families, 200% below the poverty level. Most of these individuals are those who are Medicaid eligible, many of which we serve. Next slide, please. People of color are overrepresented in many occupations within frontline industries. Just over 4 in 10, 41% frontline workers are Black, Hispanic, Asian American, Pacific Islanders, or some category other than white. Hispanics are especially overrepresented in building cleaning services. Blacks are more overrepresented in childcare and social service industries. Workers of color are 56.7%, particularly overrepresented in the following occupations: bus drivers, transit, and inner city occupations. Recently, there was a video, next slide, please. There was a video of a bus driver from Detroit who was very upset about someone not practicing best practices on his bus. And he gave a very passionate concern about people not following best practices. And 4 days later, he died from COVID-19. So healthy people are at risk of contacting the infection, especially if you're working at those places named in the grocery stores. If you're driving buses, you can be well today and very ill tomorrow. Pregnant people seem to have the same risk as non-pregnant people. People who are at increased risk are those in nursing homes and other long-term facilities such as prisons. Pre-existing conditions are very high in African-American communities, and they're listed: cardiovascular disease, HIV, diabetes, transplant recipients, asthma, chronic lung disease, hypertension, cancer, severe and often life-threatening illness, as well as smokers. Next slide. When you think about who gets COVID, obviously, you know, we've talked about this. African Americans are affected by these health problems at a higher risk than the overall population, so that these documented health disparities place us at a greater risk of not only developing the infection, but also having worse outcomes, as exhibited by the high amount of death. In Michigan, African Americans make up 14% of the population, but comprise 33% of the cases of COVID-19 and 40% of the deaths. In Milwaukee, Wisconsin, as well as in Louisiana, African Americans make up 27% of the population, but comprise almost 50% of the cases and 81% of the deaths. So it's interesting, you know, there are a whole lot of populations. The white population also smokes at the same risk, if not a higher risk, also have some of the same health disparities that we have, but the key difference is that they are not dying at the same rate. So there are some factors that are included into why that happens, and I have some of my thoughts of my own about that. In particular, we tend as African Americans to suffer too long. That when I was in pain for 8 hours before I finally decided to go to the doctor. It is recommended that when you begin to experience symptoms that you get treated immediately, that you go get tested. You may have to advocate strongly for your testing, but it's important that you don't wait and try to self-treat, to get out and to get services and get assistance as soon as possible. Next slide, please. So, as I mentioned earlier, that a high rate of social service workers are African American. We work in the community. Most of the services that we provide are face-to-face services. The basic element of services include engagement, which is a really personal relationship that you have with your client. It's usually when you begin to develop a rapport. That is done face-to-face. You get to talk to them, they feel comfortable with you, and once that happens, you go to the next stage of collecting information in order to do an assessment and to identify an intervention. So COVID-19 is changing the culture of the way that we do business. Having a relationship with your social service provider makes it a lot easier to communicate some of your challenges. We see that as we are dealing with over 700 clients, most of which all of the services were face-to-face over a month ago, and now they all are done by phone. Fortunately, the engagement has been established, but we see that individuals are experiencing higher rates of anxiety, higher issues of isolation and concern. Depression is increasing, and having the challenges that prevent intervention and evaluation and a quick termination. So the way that we do business is changing, but there is other opportunities. Next slide, please. So the social service opportunities ensure that clients have mechanisms to receive telehealth services. Medicaid has done a great job and gave a waiver in Louisiana, so we don't necessarily do traditional telehealth services where you see the client, where you can have those services on the phone. We find that clients need frequent contact, where you may not talk to a client for an hour on the phone, but they appreciate having regular contact throughout the week, where you're calling to check on them, that you are educating them on best practice and how to identify resources that can meet the client where they are in the community or at home. There are some resources that are dropping off food and delivering food to the elderly. There are options where groceries can be delivered. We have gotten food boxes and put them on the porch so clients can get those food boxes and have access without breaking the social distancing and ensuring that their basic needs are met. It's also important that we provide training to implement problem-solving methods, as I just spoke of, using telehealth. especially if you are beginning to work with a client, it may be a lot more difficult to engage. That process may take longer, but it's valuable, and training is available to assist with how to evolve as services evolve. Develop community networking in order to secure available resources. We have been fortunate in our community through our continuum of care that they've identified resources. Unity has been an excellent partner in the greater New Orleans area, identifying resources, sharing resources, and ensuring that all clients are our clients and that they make sure that we provide a good and timely service. So I appreciate Martha and her team for that. Next slide, please. Other opportunities that exist are social services provide face challenges with providing services and caring for their own families. So many people with master's degrees who are working at home, just as Pascale described, they're short order cooks now, their kids are, they're educators now, they're having to log on and help their children do the new math, and it is a challenge for them to balance their work. So we're fortunate to have the opportunity to provide hero pay, as Dr. Kellum explained, to the frontline workers, those in the community working daily, because we recognize that they are having challenges at home. I have a college student and a senior in high school who is more concerned about not getting graduation gifts than graduating. But it is really important that we identify and meet the needs of our service providers and give them the space and latitude to care for their families, as well as to care for vulnerable people in the community. We have to ensure providers have appropriate technology, including hardware, software, internet, and telehealth systems. Can't automatically assume that your lowest paid workers have access to Wi-Fi. You may need to purchase them a hotspot. You may need to purchase Wi-Fi so they can continue working. You may need to help them with a laptop, because everyone doesn't have those things, and they make providing services a lot easier. In addition, provide ongoing training that includes safety, social competency, and confidentiality. Ensure maximum protection in the community via masks, gloves, and disinfectants. Identify resources to assist providers with childcare and homeschooling. Develop a merit-based increase in incentive opportunities for providers, such as the hero pay. Next slide. The references were from the World Health Organization and Dr. Bernie Gallman of South Carolina Association of Black Social Workers. The National Association of Black Social Workers is focused on addressing African Americans issues on a regular basis. COVID-19 is high on our list. Today, I am officially the 14th president of the National Association of Black Social Workers. We are interested in having others come out and share their expertise and work to try to stop the injustices that are faced in the community and to minimize disparities. Thank you.
Thank you, Melissa, for your excellent presentation, and to Lecia as well. Folks, keep the questions coming in. A lot has come in through the the Q&A at the bottom of the screen that you could type in your questions. I'm going to go ahead as moderator, and I know some questions were answered in the chat, but I'm going to throw some out to the panelists that came in. So there was an earlier question around, can someone talk about the gender intersection of race and homelessness and infectious disease rate, specifically around Black women? I wanted to throw that out to some of the panelists if they have any additional thoughts on that.
Well, that's, when the occupations that I mentioned, childcare in particular, and those direct care workers are predominantly women and women of color. When you go in your grocery stores, you primarily see women and women of color. And not to mention, as the data stated, that many of those women have children. And a lot of grocery stores that I work in, they do not have masks on. I have given gloves that I've had to women who are working in the community, because they really face the challenge of not having the opportunity not to work. They have to go into work. Many may have stimulus checks that came, but those are short-lived. Rent still has to be paid. Food still has to be purchased. So women are impacted greatly. I'm very proud of the women I see, but I think that, we should support them and recognize these heavily social workers, primarily female. I have a staff of over 44 MSWs, and 37 of them are African-American females. So race and gender, they are the helpers and the caregivers, and we definitely need to recognize that they are highly at risk, and because they have to be.
Thank you. Oh, and Pascale, so this is Sean too. Just to make sure that you've seen, Mindy organized a lot of questions for you, so she sent them to your email. So I know it's kind of challenging just looking through the Q&A. So you can do, you can go from back and forth, because some of the questions I see that she wrote in her email, I don't necessarily see in the chat. I mean, in the Q&A.
Yeah, thank you so much. I'm opening on my email. And so I just wanted to revisit that one because I think that was brought up a little bit. I know I had answered in the chat as well, but I wanted to also allow some time for some other panelists. I don't know if anyone else wants to add on to that question. But I also just add, I think, we're not seeing enough reporting too around the states. I shared in one of my slides, the National Association of State Health Policy shared that about only 25 states are reporting on the demographic data of COVID cases and deaths, and not necessarily comprehensively. And so we really need to push for all states to be reporting this data, and also at the national level. And so another question that came up for Lecia to talk a little bit more about how St. Joseph is paying frontline workers more. A few questions came in around the hazard pay and any recommendations for how other communities and programs can find funding to do that.
Yes, I figured that would come up. One of the things that people may be aware is that in Los Angeles and Los Angeles County, we passed an increase in tax initiative that gave us $355 million to focus on homelessness given the great crisis. And it is in some of those funds that we've been able to look at any underspending and see if there's a way to maintain and increase services and also make available hazard pay. We started with a conversation of around 10% increase, and it ranges from 10%, and some agencies, depending on underspending, we're able to allocate a little bit more. So that's the first place. And you won't always have underspending, and you won't always have extra resources that target the homeless. Another way to kind of think about this is to look at the foundation community to see if they might be willing to provide assistance in covering a gap for hazard pay. Perhaps you're paying at $15 an hour and you want to do time and a half for the direct service engagement that's happening in the field. So I would be happy to talk to folks offline. But again, we know it's happening in some areas of the country, and we need to make folks aware, number one, that it's happening, that it's a possibility, and that it's critically important to support people who are going out there every day putting their lives on the line.
Mm-hmm. Great suggestions. And another question came in about potentially if you could provide any specific suggestions for things people can do right now to better ensure that Black people experiencing homelessness are getting tested and treated at more equitable rates.
I think it's it's important to note what we've covered here and what Chandra and the Racial Equity Network is identifying. We need to make the information available to our elected officials and to systems of care within our cities to, number one, help identify and show who will be most likely to be hospitalized, which will increase the crisis and the number of deaths. That's number one. I'm proud to say that in LA County, we are going to start to do mass testing in encampments. And we are already doing some of that and ramping up tremendously in the areas of the shelter spaces and hotels. But we particularly need to get out to the encampments where we know there could be spread and a great number of people at risk of dying on the streets. And so we are scaling up, and We're going to have some test kits ourselves, I guess, as an agency, going out to encampments and using our relationship with folks and the trust that we've been able to establish to really encourage them to allow us to test them, and there'll be rapid results. So that's under construction as I speak, and hopefully will launch in the coming days.
And in addition, I definitely think we have to advocate. We have to advocate strongly for.
Oh, Melissa, you're going out again. I don't know if you get closer to the screen.
Yeah. Can you hear me now?
Perfect.
Okay. I think additionally, we have to advocate. You have to advocate strongly. I had someone tell me that they had to make several calls to their insurance company. So if they have Medicaid, if the homeless has Medicaid, and I recommend that if they cannot walk in and get a test, that you call the insurance company and advocate for them to be tested, even in a pre-authorization mode. That is what happened to him. He had to call several times. He was a healthcare and he was advocating for himself, and he had to make 8 calls. And then eventually he was allowed to go take the test, and he in fact was positive. So you should not necessarily wait till the symptoms have seriously exacerbated. I think you really should go advocate. And if you are able to advocate with or on behalf of your client, I strongly recommend it.
Great points. And thank you for the great questions that are coming in. Another question, it just kind of blanketly, just are there any recommendations, or do you know of communities that are adopting a racial equity lens to address COVID and homelessness?
Well, that's a tough one, isn't it? I mean, I know that we
Yeah.
have been embracing a racial equity lens in LA, and I have been speaking with the commissioners at the Los Angeles Homeless Services Authority and saying, okay, so what does that mean about how we are approaching the crisis here in LA? And one of the things we know is data, data, data. So we know that the Mark Ridley Thomas and other board of supervisors have required that Los Angeles County Public Health begin to track racial data, and that's why I was able to give you that data. And I just emailed them. They don't know me, and I got that data. So that's one thing, is data is important. And once you have the data, then we need to increase testing. We did open up some additional testing sites, and one was in a predominantly Black community, and that's going to be critically important. And so I think that's the beginning, is one, lead with data, testing, and then the next step is, once we have all of those pieces of information and we see who's dying, then when we are trying to protect people who are on the streets and coming into shelter, which triage methodology we use and who and where we place them needs to be informed, which means, hey, a lot of those folks should be going into those motels and shelter spaces that allow them to shut the door or be more secluded. And so again, in LA, we're doing our best to use those principles. It's at an agency level, a city level, a county level. It's important that LASA reminds us to use a racial equity lens, and it's going to take all of us to hold the system accountable.
Mm-hmm. Absolutely. Just pausing to see if there's anything that Sean or Melissa wanted to add to that.
No, I totally agree. And I think from an acuity basis, I think based on where you work in those occupation that we're talking about, African Americans being highly at risk, I think we should really advocate for those.
Oh, Melissa, you started off great, and then we lost you a little bit.
I think that, we should look at elevating the opportunities for African Americans and those working in those frontline occupations to be tested. At this point, the data is helping tremendously because we see who's dying, and if we want to prevent it, we need to do more on the front end to prevent and test.
Melissa, thank you for bringing that up. I will say that just yesterday, I received an email from LASA, from the interim head, Heidi Martson, basically indicating that we kind of are separated by service provider areas and regions. But as the regional head on the west side, we will be making testing available to staff. So that is critically important. And I want to just say how pleased and reassured I am that the folks on the front line will also have access to testing. So thanks for bringing that up, Melissa. And I know that is something we need to be advocating for as well. And let me just say, I'm the lead on the west side of Los Angeles. We're also in South LA and downtown, but it will be throughout the county. So all of us over a region will be the sort of testing hubs, and we'll be sending emails out in the next couple of days to heads of nonprofits doing this work who are wanting to make testing available to their students.
Excellent. And I think we might have time for a couple more questions. I'm going to try to squeeze them in. Someone asked if we could address the intersection of race and age.
Race and age is what you said?
Yes, race and age.
I would need to know a little more. The correlation, I'm not really sure about that question. I'm sorry.
Yeah, and whoever typed that in, if you want to add on to it, I know, just thinking about, particularly in the homeless population, as those who are over the age of 50 are the fastest growing kind of subpopulation, and particularly in places like Los Angeles and New York City, and have multiple, right, comorbidities, trimorbidities, and so they're at particular risk. And when you think about access and the ability to shelter in place and the challenges for that for folks with maybe mobility and other kind of compounding issues that make them acutely at risk. And so I think there's definitely a challenge there. I don't know how communities, I think I learned in New Jersey, they were prioritizing some of their motels and hotels, a subset for older homeless adults, but love to hear if folks have heard other things from the field. And then I'll try to throw in another question. So someone added that COVID decisions are being made really quickly, and executive decision-making teams are probably not reflective of populations served at greatest risk. How can organizations influence state-level policy to ensure strategies and implementations of new funding are equitably distributed?
Well, I will just say that one of the things that inspired us with the recommendation from the ad hoc committee is that we change the structure of our executive teams. And St. Joseph Center has been working for several years on making sure that we have diversity and equity at all levels of the agency. And no, I am not there. I haven't accomplished that fully, but I have an eye on it. And it's something that's very important. And so when I pulled a task force together about 6 weeks ago, when this whole thing started to come down, it was headed up by an African-American woman, and is a very diverse team looking at all types of issues and challenges and who could work from home and who would not. And so it was that group that inspired me to add extra vacation days and make sure that people did not have to deplete all of their resources. Yes, we are buying Wi-Fi. Yes, we are allowing people to work through the night. Because we know that if you are a person of color, you got your kids at home, you're running daycare, you're doing work. So just really trying to be gracious and allow people to be able to do this work, but not lose everything. I'm trying my best not to furlough anyone. We're going to hold on to the team. I'm going to go to our partners and ask for help when I need to. So again, diversity is important, and certainly the way that we respond. We noticed that one person wasn't able to get her reports in, and because she didn't have proper Wi-Fi, so we're going to pay for the Wi-Fi. And I do believe that that is the way we address this from a racial equity lens.
Talk about showing up. Thank you. And I realize we're at the hour about. I just want to give, I think we have a minute, or if folks want to give a last maybe comment or last thoughts. But in the meantime, I want to thank panelists and NEH for putting on this very important conversation and for folks' active participation. I know that for the questions we didn't get a chance to answer, we'll be responding via email. Maybe I'll turn it back to you, Sean. Not sure if you're on mute.
You know what? I was muted. I was talking and then I realized that I was muted. So we are at the 4 o'clock, and I want to thank the three of you, wonderful panelists, and I thank you for really starting this conversation. And we will continue to have more and present more information. So I learned a lot today, so I hope people were able to take some things, at least start to think about how to center racial equity. We're all learning through this, and so I just really appreciate this presentation. And like I said, we have 2 more on the docket next week, but we will continue to talk about racial equity in all of our panels, but we will specifically focus it. So thank you, Pascale, Dr. V, and Melissa Haley. Thank you.
Thank you.
Thank
Thank you.
you. It's an honor to
well,
be a part
everyone.
of this. Thank you.